Welcome to The Explainer. Today, we are jumping into a really fascinating paper that honestly might completely change how you view a shared room. You know that feeling? Have you ever walked into a crowded space? Maybe someone clears their throat and you suddenly feel this kind of invisible tension in the air? Well, the politics of the COVID-19 pandemic have almost always been narrated as this straightforward clash between public health rules and personal freedom. But the research we're exploring today argues that this framing is just way too thin. It assumes the conflict begins with an already formed individual who's just deciding whether or not to follow an external rule. But as we know, respiratory infection doesn't really care about the fantasy that our bodies are entirely separate from one another. All right, let's just dive right into it with a question I'm sure we've all heard. When it comes to respiratory viruses, is wearing a mask just a personal choice? I mean, for the last few years, we've seen this phrase literally everywhere. You assess your own risk, you make your own choice, and you move on, right? But the question is, does this perspective actually reflect how viruses and shared spaces operate? Well, our source text shatters that premise immediately with this quote, and it really sets the intellectual stakes for how we actually share the physical world. It says, "The air between people is a material relation before it is a matter of opinion." Think about what that actually means for a second. Every shared classroom, bus, workplace, or kitchen is already organized by this unstated respiratory politics. It dictates who breathes what, who is expected to adapt, and whose ability to safely participate is treated as entirely optional. Here's how we're going to break this all down today. 1. The privatization of air. 2. Communitas versus Immunitas. 3. Mask blocks as mutual aid. 4. Community infrastructure. 5. Obstacles and legal. And finally, 6. Breath as shared duty. Starting off with Section 1, the privatization of air and how we handle post-emergency governance. Let's look at how society has basically framed pandemic survival as a completely individual burden. The paper points out that as institutions started rolling back mandates, keeping the air clean shifted from being a public good to essentially a private perk. We entered this era of post-emergency governance, where harm wasn't necessarily denied outright, but rather it was made administratively tolerable. Infection becomes just life. Reinfection becomes expected. And masking? Well, that just becomes a preference. The heavy burden of adaptation is pushed entirely onto the shoulders of those who need protection the most. They are told to just assess their own risk and bear the social cost of asking for accommodations. What you should really take away from this is that personal choice actually masks a hugely uneven distribution of money, time, disability, and workplace power. One person's choice not to mask in a crowded room is literally another person's exposure condition. Moving right along to Section 2, Communitas versus Immunitas, looking through the lens of Roberto Esposito's theory. Okay, this brings us to a massive paradigm shift. Esposito completely unsettles our normal, everyday idea of community. Usually, we tend to think of community as a shared identity, or maybe shared property. But Esposito argues that community is actually about shared obligation. It's about what we owe each other. He calls this communitas. On the flip side of that is immunitas. And in this political sense, immunitas doesn't just mean biological immunity from a virus. It means being exempt from the shared obligations that actually make up a community. It's the ability to basically say, hey, my protection is my problem, and my behavior remains totally unchanged by your needs. The author warns against two huge modern errors we tend to make in public health, noting that the real issue isn't the physical mask itself, it's the social relationship organized around it. The first error is treating any demand for a mask as a barrier to normal life or human intimacy, and the second error is assuming that just because a vulnerable person can wear a high-quality N95 respirator, the rest of society is just off the hook and has no further responsibility to them. Both of these errors miss the point entirely. The question isn't just mask or no mask in some abstract sense. The real question is whether masks are used as private shields to exempt us from caring for others, or if they're used as shared infrastructure to build common capacity. Which brings us to Section 3, mask blocks as mutual aid, focusing on grassroots responses. So what does this actually look like in practice? Well, enter the mask block. A mask block is essentially a grassroots response, stepping in to ensure that vital tools like N95s are available to communities completely without the barrier of cost. They are these independent groups that jump in where state and market infrastructures have just left massive gaps. And they don't just hand out masks. They provide rapid tests, they share crucial information about clean air, and they help make events accessible for folks dealing with long COVID or other disabilities. And the sheer scale of this is absolutely wild. By July 2026, the worldwide directory listed 234 active mask blocks and community providers. So we're not talking about a few isolated incidents here. They represent a widely distributed practice across multiple regions, and so many of them were actually created and led by disabled people and folks dealing with long COVID. The text draws on scholars like Spade and Kropotkin to really highlight a crucial distinction here. These blocks practice mutual aid, which aims for solidarity rather than the traditional hierarchy of charity. If you look at the difference in these models, charity preserves a strict hierarchy between the giver and the recipient. It's very top-down. But mutual aid, that's reciprocal. It recognizes that COVID-19 is a long-haul disaster, not just some brief passing emergency. Mask blocks operate on this core principle that systemic conditions are what need to change, and they do this by sharing resources horizontally across the community. All right, Section 4, building community infrastructure and creating what's called access intimacy. Let's look at what these folks are actually doing on the ground. They are building out 5 very specific types of infrastructure. First up, procurement. They're buying high-quality respirators in bulk, so everyday individuals don't have to try and navigate confusing or super expensive markets. Second, access. They're distributing these respirators right at the point of need, at protests, local schools, and workplaces. Third, knowledge. They circulate vital, trustworthy information about aerosol science, mask fit, and ventilation. Fourth, relational. Connecting COVID-cautious people so they can actually find each other and organize. And fifth, political. Fighting to keep the pandemic visible in a society that is rushing headfirst to normalize the crisis. And by doing all this, they create what disability justice scholars like Mia Mingus call access intimacy. This is absolutely huge, guys. Think about it. A world of highly individualized precaution forces vulnerable people to constantly explain, justify, and basically beg for safer air every single time they enter a room. Honestly, it's exhausting. Mask blocks lower that social cost. By making masks readily available right at the door of an event, they spare people from being singled out as this difficult, solitary exception. They convert what is normally an exhausting individual negotiation into just a normal collective practice. But of course, it's not always smooth sailing. Let's look at Section 5, Obstacles and Legal Battles, covering the real-world friction and limitations. Building this kind of local infrastructure definitely comes with some serious friction. Organizers often face severe burnout because they're absorbing all this demand that was basically abandoned by major institutions, which leads to total exhaustion. There's also the risk of platform capture, where sometimes the focus accidentally shifts to chasing social media metrics rather than serving actual local community needs. And more critically, the text reports data from the International Center for Not-for-Profit Law detailing that as of September 2025, 23 states and Washington, D.C. actually had laws limiting face coverings in public spaces. These laws raise massive First Amendment concerns and can heavily chill expressive activity. So this creates a really stark double bind for vulnerable folks. On one hand, society is essentially telling them, hey, your health is your own responsibility. You need to protect yourself. But on the flip side, increasingly, visible collective masking marks them for social exclusion, harassment, or even policing. It reveals that this immunitary public permits protection, but only when it remains totally private, quiet, and non-disruptive. Mask blocks, therefore, sit right at the very intersection of public health and civil liberties. They are defending the public legitimacy of simply appearing masked in the world. And that leads us to our final part today, Section 6, Breath as Shared Obligation and Reorganizing Protection. So how do all these interconnected threads finally come together? Ultimately, mask blocks prove that public health can absolutely function at a community level, completely rejecting the premise that everyone is just out there on their own. They change the practical default. Instead of bring your own mask if you want one, the message shifts to we provide them because we care. Instead of telling people to do your own research, they offer situated, collective knowledge. Just placing a simple box of N95s at the door of an event reopens a big question that society really tried to settle. It asks why respiratory access was ever treated as optional in the first place, and who exactly was being silently excluded from the room. The really vital takeaway here is that true community sometimes literally requires boundaries and filters to make sure nobody gets left behind. This is the core theoretical point of the entire paper. Communitas is not the absence of precautions. Community is not proven by taking off your mask to show your face. Under pandemic conditions, shared obligation absolutely requires barriers and filtration. The problem was never biological immunity itself. The problem is when we use our immunity as an excuse to exempt ourselves from caring for everyone else. So, as we wrap up this explainer, I want to leave you with this final, kind of profound thought for the next time you step into a crowded room. If we accept that protection isn't merely mine and exposure isn't merely yours, that the air between us is a very real, material reality we all depend on, then how should we be sharing it? Think about what access intimacy could actually look like in your own life, and how we might move from a mindset of private exemption to one of true common capacity. Thank you so much for joining me for this analysis, and as always, keep questioning the structures around you.